Hi, this is Dr. Kanu from Gastropedia. Welcome to our discussion of postoperative Crohn's disease recurrence, brought to you by Gastropedia. In this discussion, we'll focus on the risk factors that predispose patients to Crohn's disease recurrence after ileocystectomy, and then proceed to discuss a recent study that focuses on management of post-surgical Crohn's disease. Make sure to check out our other videos at MyGastropedia.com. Let's begin by talking about why postoperative Crohn's disease recurrence is significant. As you may know, that about half of patients with Crohn's disease will require surgical intervention within 10 years of diagnosis. Of these patients, those who develop recurrence are associated with increased complications, multiple surgical interventions, poor quality of life, and significant healthcare costs. Given that these postoperative recurrences are detrimental to our patients, it's important to understand the risk factors for recurrence. Risk factors for recurrence include smoking, prior intestinal surgery, and fistulizing disease. Now, there is some data that supports perianal disease and bowel resections of greater than 50 centimeters as contributing to recurrence risk, but the data is conflicting. In terms of post-operative recurrence management, there have been some studies that have examined various medications. For example, aminosalicylates, probiotics, and budesonide have not been shown to decrease recurrence. Medications such as azathioprine and 6-mercaptopurine have been shown to decrease recurrence, but the toxicities and side effects associated with these medications cause many patients to drop out of the study, making the data skewed. In addition, nitramidazole antibiotics have been shown to improve recurrence risk. These antibiotics include metronidazole, otherwise known as Flagyl. The difficulty with this group of antibiotics is that though they reduce recurrence risk in the short term, over time they will lose their effects and have not been shown to prevent recurrence by the 1-year post-operative mark. This brings us to a class of drugs called the TNF-alpha inhibitors. TNF-alpha is a naturally occurring component of the immune system that drives the movement of white blood cells. TNF inhibitors block the function of TNF, thus decreasing the immune response and in turn decreasing inflammation. Now recently, there has been a double-blind randomized controlled trial showing that infliximab, otherwise known as Remicade, has been shown to reduce recurrence post-operatively. Now the question is, do all the TNF inhibitors prevent recurrence post-operatively? Well, let's take a look at the most recent study in the TNF inhibitors, specifically adalimumab, otherwise known as Humira. Recently, the American Journal of Gastroenterology published a prospective randomized controlled trial that compared adalimumab to azathioprine and mesalamine in preventing Crohn's disease recurrence after ileocystectomy. Let's take a quick look at this study. This randomized prospective trial had 3 treatment arms. One arm was the use of adalimumab, the second was azathioprine, and the third was mesalamine. The study was looking to see if recurrence was different in these arms. Plus, it looked at endoscopic and radiographic recurrence as well as quality of life as a secondary outcome. Exclusion criteria for the study was having Crohn's disease for more than 10 years, with this being the first operation, active disease that was not resectable during the surgery, and if a stoma was present. Again, the primary outcome was to assess recurrence in the 3 treatment arms up to 2 years after surgery. Ileocolonoscopy was performed at the 12 and 24-month mark post-operatively. Treatment in each arm was begun from 2 to 4 weeks post-operatively. The way endoscopic recurrence was assessed was by the Root-Geert score that was previously established. This scoring system looked at the number of ulcerations and distribution of inflammation to apply a score for endoscopic assessment. Recurrence was defined as a score of 2, 3, or 4, while remission was a score of 0 or 1. In this study, the endoscopies were video recorded, so not only did the endoscopist provide a score, but a blinded investigator and the principal investigator assessed disease via the recorded endoscopy and provided scores as well. Whichever score had the most votes of the 3 was a score picked for that patient. Disagreement among scores only occurred for one patient where there was a difference between the initial endoscopy score and the blinded investigator, requiring the use of the principal investigator's score to make a decision. Clinical and radiographic recurrence was assessed using the scale detailed here. In addition, the CDAI score, otherwise known as the Crohn's Disease Activity Index, was calculated. Now keep in mind, the CDAI score has never been validated for the post-operative setting. If patients had a CDAI of greater than 200, it was considered recurrence, but if less than 150, it was considered remission. Finally, the last assessment was the IBDQ, which assesses the patient's quality of life and I feel is one of the most important assessments in the study. The IBDQ assesses bowel-related symptoms, social function, emotional status, and creates a score from 32 to 224. Remission is considered if the score is 170 or greater, while lower than that is correlated with a poor quality of life. This assessment was completed in the preoperative setting, 12 months postoperatively, and 24 months postoperatively. It's always important to look at the demographics of each arm to make sure that there is no difference between the treatment arms that could contribute to outcomes. We see in this table that there is no significant difference between the number of smokers in each arm, and that the disease location was not significantly different among the different arms. Now, one important point is that there were a total of 9 who did receive infliximab prior to being enrolled in this study. It's important to note that there is no statistically significant difference among the 3 therapeutic arms in terms of previous infliximab exposure. In general, there is no perceivable significant difference among the 3 groups that could bias the findings. Once the results were analyzed, there are several differences among the different treatment arms in terms of endoscopic recurrence, clinical recurrence, and quality of life. In terms of endoscopic recurrence, there was only 1 person of 16 in the adalimumab arm versus 11 in the azathioprine and 15 in the mesalamine arm that developed recurrence. In addition, the maximum severity of the recurrence was a 2 in the adalimumab arm, 3 in the azathioprine arm, and 4 in the mesalamine arm. From this data, there was statistical significance between severity and number of recurrences in the adalimumab arm versus the azathioprine and mesalamine arm. In contrast, there was no statistical difference in the level of recurrence between the azathioprine and mesalamine arms. These differences further extended to clinical recurrence. Adalimumab had statistically less clinical recurrence when compared to the other 2 arms, while the recurrence and severity between mesalamine and azathioprine were not statistically significant. This brings us to the secondary outcome, which is quality of life. Quality of life, as measured by the IBDQ, was not statistically significant among the 3 group of patients prior to surgery. At a 2-year follow-up, we see a different picture. In each of the treatment arms, we note that the adalimumab arm, where 14 of 16 had a higher quality of life and met a score of remission, while only 2 in the azathioprine and 3 in the mesalamine arm were able to do so. The difference between the adalimumab arm and the other 2 treatment arms was statistically significant. However, no statistical significance was noted between the azathioprine and mesalamine arms in terms of quality of life. Though this is an excellent study, it's important to point out the limitations and weaknesses. First off, 1 patient in the adalimumab group withdrew from the study because of atopic dermatitis. 2 patients in the azathioprine group had to be withdrawn because of Crohn's disease exacerbation, and the other due to pancreatitis. Finally, 2 members of the mesalamine group had to withdraw due to Crohn's disease exacerbations that required steroids. Now, there were members in the study that had prior infliximab exposure, though their distribution among the 3 arms was not statistically significant. In addition, the sample size was rather small and really could bias the results. Finally, there was no placebo group used, but the authors do note that mesalamine in the past has been shown to be no better than placebo, making the mesalamine essentially a placebo arm. So does this mean TNF inhibitors are really for everyone? Well, not so fast. Like any therapy, the therapeutics in Crohn's disease need to be tailored to the disease location and severity for each individual. Here's an example of a plan for stratifying patients based on their disease individual characteristics. In this schematic, each patient is sorted based on their risk of postoperative recurrence. Based on the risk factors and previous treatment, they are sorted into different treatment arms. Well, that was a review of the risk and management of postoperative Crohn's disease recurrence. I hope you enjoyed this video. If you did, make sure to give this video a like, share this with your friends, comment, and subscribe. You can follow us on Twitter and Facebook at MyGastropedia. Make sure to check out our website at MyGastropedia.com and help support us. This is Dr. Kanuru, and thanks for watching.